Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit, currently academic JR in the Department of Pharmacology, AIMS Kalyani, and I am back with one of my seminars. So, without wasting any time further, let's get into today's topic. So, in today's seminar, I am going to discuss about the topic that is drug-induced liver injury, which is also known as Dili. Okay, so drug-induced liver injury. So, in this seminar, we are going to discuss the topic under the following headings, that is introduction to drug-induced liver injury and the epidemiology. It will also include about the definition of the drug-induced liver injury, then the risk factors for drug-induced liver injury, then the associated drugs. It means the drugs which are responsible for causing the drug-induced liver injury. Then coming to the classification of the drug-induced liver injury, it can be done based on the clinical manifestation, the mechanism of hepatotoxicity by which the drugs causes the drug-induced liver injury. Apart from that, the histological findings also can be used for classifying the drug-induced liver injury. Then coming to the clinical manifestations and then diagnosis and the differential diagnosis for the drug-induced liver injury. Then the causality assessment of the drug-induced liver injury, for which we have different scales. Then the management of the drug-induced liver injury, prognosis, and finally how to prevent the drug-induced liver injury. So first, introduction and epidemiology. So drug-induced liver injury is basically a liver injury which is caused by various medication, herbs, or other xenobiotics. Xenobiotics means any compound which is foreign to the human body, and it leads to abnormalities in the liver function test or liver dysfunction with the reasonable exclusion of the other etiologies. So these are the key points, that is, it is a liver injury which can be caused by various medications, herbs, and xenobiotics, and it leads to abnormalities in the liver function test, and we have to do the exclusion of the other possible etiologies. This is because drug-induced liver injury can mimic both acute and chronic liver diseases like the other diseases. So we need to exclude the other causes. So that is the reason why drug-induced liver injury is also a diagnosis of exclusion, and I will be coming to it in the upcoming slides. Now, coming to the epidemiology, that is, in the United States, the probability of an individual drug causing it, that is, causing the drug-induced liver injury, ranges from 1 in 1000 to 1 in 1 lakh, with some drugs reported to have an incidence of 100 in 1 lakh. So this 100 in 1 lakh is meant for the drugs like chlorpromazine and isoniazids. So these two drugs are implicated for causing the drug-induced liver injury in comparatively larger proportion. So that is 100 in 1 lakh population in US. And also, drug-induced liver injury is the most frequently cited reason for withdrawal of medications from the marketplace. That is, it comprises about 32% of the drug withdrawal. So 32% of the drug withdrawals from the markets occurs after the release of the drug because of the drug-induced liver injury. And Dili is, that is, the drug-induced liver injury may not be detected prior to the drug approval. This is because most of the new drugs are tested only in fewer than 3,000 individuals prior to the drug approval, and as a result, the cases of Dili with an incidence of 1 in 10,000 may be missed. So this is the reason why drug-induced liver injury can be missed during the clinical trials, and this is the reason why it is constituting the major proportion of the major reason for the withdrawal of the drugs which are already approved for the clinical use. So this is about the introduction and epidemiology of the drug-induced liver injury. Now coming to the risk factors. So in these factors, we have age, that is, adults appear to be at higher risk of drug-induced liver injury compared to the children, but it is not that children are completely out of risk. So they also have the risk of developing the drug-induced liver injury, but the adults are more prone to develop drug-induced liver injury. Next is, in sex, males appear to develop drug-induced liver injury more often with the drugs, that is azathioprine, anabolic steroids, and amoxicillin clavulinate combination. So these three, that is azathioprine, anabolic steroids, and amoxicillin clavulinate, is actually implicated in causing Dili more in the males as compared to the females. And there are some other drugs which are responsible for causing drug-induced liver injury more in females. Now coming to the next factor, that is race and ethnicity. The impact of race and ethnicity on Dili remains uncertain. So the impact is uncertain in case of race and ethnicity. Now coming to the other factors, that is obesity, diabetes, and chronic viral hepatitis. These worsens the liver injury due to the drugs like tamoxifen and methotrexate. So, if an individual is having obesity, diabetes, or chronic viral hepatitis, then the liver injury which was being caused by the tamoxifen or methotrexate in these individuals, it will be even more worse. So these are some of the other factors. Then we have genetic factors also. So we have numerous genetic polymorphisms in the CYP enzymes, that is the metabolizing enzymes, and different variation in the HLA alleles. So these also constitute the factors for causing the drug-induced liver injury. And a missense mutation, that is a missense mutation in PTPN22, that is a protein which is involved in signaling control of T cells. It is implicated in the causation of almost all sorts of Dili. So this is a risk factor for almost all sorts of Dili, that is all types of Dili. Then also several drug to drug interactions which occurs in the body are also a risk factor for occurrence of Dili, that is drug to drug interaction also. And so these are the risk factors which are responsible for causing or aggravating the chances of occurrence of this drug induced liver injury. Now coming to the associated drugs, so it has been identified that about 1000 medications and 60 herbal products have been implicated in causing the drug induced liver injury. So we have the National Institutes of Health, which maintains a searchable database which is known as liver tox. As you can see here, liver tox, for the drugs, herbal medications and the dietary supplements that have been associated with Dili. So in this database, which is being actually produced by the National Institute of Diabetes and Digestive and Kidney Disease, that is NIDDK. So this is the institute which has produced this database, that is liver tox, that is National Institute of Diabetes and Digestive and Kidney Disease. And this database is a copyright free database, so it will provide us information about the different drugs and how they are implicated in causing the drug induced liver injury. So here you can see the search this book option. So here you can type in the drug for which you are thinking that it can cause drug induced liver injury, and then you will get the details regarding that. Or else all the drugs will be arranged from A to Z in the alphabetical order just below this, and you can see the different types of interactions and the different reasons why different drugs causes drug induced liver injury. So this is basically the database for referring all the drugs which can actually lead to drug induced liver injury and what are the chances of causing the drug induced liver injury for different drugs. Now coming to the most commons. So in United States, acetaminophen, that is basically paracetamol, is the most common cause for drug induced liver injury. Following it is the antibiotics. And in worldwide, that is in over the world, the most common cause of drug induced liver injury is basically amoxicillin clavulanate combination. In India, the most common cause for drug induced liver injury is combination anti-TB drugs, that is antitubercular drugs, which comprises about 46% of the Dili which occurs in India, and it is followed by the other medications, that is traditional and alternative medicines, then anti-epileptic agents, that is basically the first generation anti-epileptic drugs, then non-TB antimicrobials, antiretroviral agents, and finally we have non-steroidal anti-inflammatory drugs. So these six group of drugs are the most commonly implicated drugs in causing drug-induced liver injury in India. And out of this also, if we have to say the most common group of drugs, then it will be the anti-TB drugs, which is constituting about 46% of the Dili cases in India. Now, a little bit about this combination anti-TB drugs. So, the combination anti-TB drugs are the most common cause for causing drug-induced liver injury in India, and it is also the most common cause of drug-induced acute liver failure, and it is the second most common cause of drug-induced acute on chronic liver failure, that is ACLF, drug-induced acute on chronic liver failures. So, most common cause for Dili, combination anti-TB drugs in India. Then it is also the most common cause for drug-induced acute liver failure in India. Then it is second most common cause for drug-induced acute on chronic liver failure in India. And why do we have increased tendency of drug-induced liver injury with the use of anti-TB drugs? This is because anti-TB drugs are usually given in combination, that is we are giving many drugs together, and that also at a very high dose, that is large daily dose of particular drugs are being given, and usually the TB patients are malnourished. Usually the patient will be cachectic in nature, And apart from that, individuals can also have NAT2 gene polymorphism, that is N-acetyl transferase, which is responsible for acetylating and metabolizing the antitubercular drugs. So all these factors togetherly lead to increase in the occurrence of DILI with the usage of antitubercular drugs. And Dili from antitubercular drugs mostly occurs within the first 2 months of the treatment, that is first 2 months of the antitubercular treatment. As you can see here, rifampicin, isoniazid, pyrazinamide. Ethambutol is not that hepatotoxic in nature. So these three drugs, that is rifampicin, isoniazid and pyrazinamide, these are the major drugs which are responsible for causing hepatotoxicity, that is drug-induced liver injury due to antitubercular therapy. Now coming to the classification of the DILI. So DILI is initially characterized based on its clinical presentation. And when the liver biopsy is being performed, that is liver biopsy is not done in all cases of drug-induced liver injury, but if the liver biopsy is being done, then we can assess the degree of damage it has caused, the drug has caused to the liver, and then DILI can be further categorized based on the histological findings. So here you can see the different types of classifications. First, clinical laboratory, that is based on the clinical manifestation. The drug-induced liver injury can be hepatocellular type, it can be cholestatic type, or it can be mixed hepatocellular cholestatic type. Then, based on the mechanism of hepatotoxicity, the DILI can be classified into two categories. That is, one, there is direct hepatotoxicity which is caused by some of the drugs, and idiosyncratic reactions. That is, these are the reactions which are not predictable. That is, these are not dose-dependent reactions of the different drugs, and it can be further immune-mediated or it can be metabolic. So these are the two different mechanisms by which the drug-induced liver injury can occur. Now coming to the classification based on the histological findings. So in histological findings, we have several findings, that is cellular necrosis, then we have apoptosis, that is basically the death of the cells, then we have cholestasis, then we have steatosis, that is basically ballooning of the hepatocytes, then we have fibrosis in the liver parenchyma, then we have phospholipidosis. So it is basically the entrapment of the phospholipids in the vesicles, that is in the lysosomal vesicles of the hepatocytes. And then we have the granulomatous type, that is formation of the granulomas without any caseous necrosis, that is without any caseous necrosis. Okay, so this can be also one of the type. Then we have sinusoidal obstruction syndrome, that is basically obstruction of the hepatic sinusoids. And we have one more variety, that is Buchiari syndrome, where there is obstruction that is outside the liver, that is extrahepatic obstruction of the veins. So in both these cases, that is whether it is sinusoidal obstruction syndrome or whether it is Buchiari syndrome, in both the cases there can be engorgement of the spaces within the liver, that is the liver can enlarge, and it will give an image which is just same as that of an enlarged liver in case of congestive heart failure. So these are basically the histological findings, the classification of the DILI based on the histological findings. And details of this is actually more about pathology, so we will not go into the details of the histological findings. Now coming to the clinical manifestation, so that is based on the clinical presentation. As I have already mentioned, it is hepatocellular injury, then it is cholestatic injury, or it can be mixed injury. So what are the key features to say that it is a hepatocellular type of DILI, that is hepatocellular injury? Hepatocellular injury, we can also say it as hepatitis, that is inflammation of the liver cells. So here there will be disproportionate elevation in the serum aminotransferases, that is ALT and AST, that is alanine aminotransferase and aspartate aminotransferase, compared to the alkaline phosphatase levels, that is ALP. And in cholestatic injury, that is cholestasis, there will be disproportionate elevation in the alkaline phosphatase, that is ALP, compared to the serum aminotransferases, that is ALT and AST. So what are the differences? In hepatocellular injury, ALT and AST will be very much high compared to ALP, whereas in cholestatic injury, ALP levels will be very much high as compared to ALT and AST. And in both the types, we will have synthetic functions which are abnormal. Synthetic functions means the liver is responsible for producing clotting factors, for producing proteins. So those will be decreased in both the cases. And also there will be increase in the serum bilirubin in both the types of injury. And when we have mixed variety, we will have features of both, that is the features of the hepatocellular injury and the features of the cholestatic injury. So this is based on the clinical presentation, how we can differentiate between the different types of drug-induced liver injury. Now, based on the mechanism of hepatotoxicity, how we are classifying drug-induced liver injury. So, injury may be in a dose-dependent, predictable way. As I have already mentioned, that is direct hepatotoxicity. So, it is basically for the drugs which we know are already hepatotoxic, and then injury can be in an unpredictable way, that is idiosyncrasy. That is idiosyncratic fashion and diet hepatotoxicity. So, in diet hepatotoxicity, what it is being mentioned is that it is caused by intrinsically hepatotoxic drugs. It means we know that these drugs with increased dosage will have hepatotoxic effect, and that is the reason why most of these intrinsically hepatotoxic drugs are being removed from clinical use by the regulatory agencies from the market. Examples include carbon tetrachloride and chloroform. So these drugs are no longer being used for clinical use, but there are some other drugs like acetaminophen, that is acetaminophen, that is basically paracetamol, which also leads to hepatotoxicity and which is also an intrinsically hepatotoxic drug, but that is still not being removed from the clinical use. This is the reason, this is because these drugs, that is acetaminophen, is actually hepatotoxic in nature, but only at a very larger dose. That is only at a very high dose only it will be causing hepatotoxicity. But carbon tetrachloride and chloroform, even in smaller doses, they can cause hepatotoxicity. So that is the reason why they are being removed from the market, but this drug, that is paracetamol, is still present in the market, and we have to take this with proper care, that we should not go to such large doses that it can cause hepatotoxicity. Next is indirect hepatotoxicity. In indirect hepatotoxicity, the drug induces or exacerbates the liver disease. So examples will be including de novo development of fatty liver or its worsening with the use of tamoxifen, and another example is the anti-neoplastic agents, that is anti-cancer drugs, can also activate viral hepatitis. So these are the two examples for indirect hepatotoxicity, that is one with tamoxifen and one with the anti-neoplastic agents. Now coming to the classification of the Dili based on the histology. So as I have already mentioned, it can be acute or chronic hepatocellular injury. So hepatocellular injury can be characterized by the hepatocyte death and necrosis. Hepatocyte death and necrosis. Then we can have acute or chronic cholestasis, and if it is a chronic case of cholestasis, then what happens is slowly the bile ducts will decrease in number, and that is called as ductopenia, which will finally lead to a condition called as vanishing duct, that is vanishing bile duct syndrome. So ductopenia, which leads to finally vanishing bile duct syndrome. So these are the features of chronic cholestasis. Then we have steatosis, that is basically the ballooning of the hepatocytes, as you can see in this image. As you can see in this image, these are the ballooned hepatocytes, and when inflammation is also along with that, then it will become steatohepatitis. Then we have granulomas, as you can see here. This is granuloma, which is not having any caseous necrosis, unlike the granulomas which are seen in case of tuberculosis. Then we can have zonal necrosis. Then we can have signs of hepatic venous outflow obstruction. Hepatic venous outflow obstruction, that is the case of Budd-Chiari syndrome, where we will be having enlarged liver. Then we can have sinusoidal obstruction syndrome, as you can see here. So you can see some of the clots which are blocking the sinusoids. Then we can have nodular degenerative hyperplasia in case of liver injury, drug-induced liver injury. Then we can have phospholipidosis, that is entrapment of the phospholipids in the vesicles of the lysosome within the hepatocytes. Then we can have pileosis hepatis. This image is of pileosis hepatis. So in this condition, what happens is there are dilated spaces within the liver parenchyma which comprises of blood. As you can see in this image, these areas which are being shown, these areas in between the normal parenchyma, this is the normal parenchyma, these areas are the area which are showing the cystic appearance. This is because of the accumulation of the blood in these spaces. So this is the case of pileosis hepatis. Now coming to the clinical manifestations. So Dili can present acutely as asymptomatic mild liver function test abnormalities, which means that some of the cases of Dili can be diagnosed even without any symptoms, but only with the abnormalities in the liver function test. And in some cases, there will be marked elevation in the liver enzymes along with the features of acute hepatitis, or there can be cholestasis with pruritus, and symptoms I will be showing in the upcoming slide. Next, chronic liver injury can also resemble other causes of chronic liver disease such as the autoimmune hepatitis. Then we have alcohol associated liver disease, and one of the major endpoint of any chronic liver injury, that is chronic liver injury, that is a drug induced liver injury, is that Dili can progress to even cirrhosis. So this can be the endpoint of chronic drug induced liver injury. Now, as you can see, the clinical manifestations under which we have the symptoms and the examination findings. So symptoms include fever. Along with fever, we can have nausea and vomiting. Then we can have abdominal pain, that is basically right upper quadrant abdominal pain. Then we can have jaundice, which will be manifested in the form of yellowish discoloration of the eyes. Then we can have echolic stools, that is basically clay colored stools, and we can have dark urine. So all these are the different symptoms. Apart from that, when we do the examination, we can get hepatomegaly in the individuals, and this can also lead to, these drugs can also even lead to some of the skin rashes and fever, as I have already mentioned, and can even lead to some of the severe conditions like Steven-Johnson syndrome. So these are basically the clinical manifestation, that is the signs and symptoms which are seen in case of drug induced liver injury. Now coming to the diagnosis. So as I have mentioned at the beginning of the presentation only, that Dili is always a diagnosis of exclusion. That is, we have to first exclude all other possible causes of the clinical manifestation. It can be viral hepatitis, it can be Wilson's disease, it can be any other issues related to liver like alcoholic liver disease, it can be non-alcoholic fatty liver disease. All these have to be first excluded, and then only we can go for the drug induced liver injury. So there will be development of elevated liver enzymes and or some non-specific symptoms after the introduction of a drug, which may indicate drug toxicity, and this will make us prompt to think of Dili. So in that case, what we have to do is, for diagnosis, we have to take the detailed history of the medications which the patient was taking. Then the drug dosing details have to be taken, and the timing of symptom onset, that is when did the symptoms start. So all these things have to be taken, and in history along with this medication history, apart from that, we'll also have to ask the patient whether the patient was taking any complementary or herbal remedies or any drugs of abuse, that is the illicit drugs. And usually Dili develops within 6 months of beginning a new medication, so this can help us to diagnose Dili. So these are the parameters which we are looking forward, that is in case of history. And apart from this, we will be coming to the laboratory part also, that is the laboratory findings. So in the next slide, as you can see, with patients with clinically significant Dili will have at least one of the following. So this is based on the AASLD guidelines, that is American Association for Study of Liver Disease. So they have provided these guidelines for the diagnosis of Dili. So at least one of these should be present. First is serum aspartate aminotransferase, that is AST, or ALT, that is alanine aminotransferase, should be more than 5 times of the upper limit of the normal value, or alkaline phosphatase levels should be more than 2 times of the upper limit of the normal value on 2 separate occasions. That is, these two should be present on 2 separate occasions, that is this or this, or that is ALT and AST more than 5 times the upper limit of the normal, or ALP more than 2 times of the upper limit of the normal, and on 2 separate occasions, and it doesn't matter whether the patient is having any symptom or not. Next, apart from this, we have another one, that is total serum bilirubin, that is more than 2.5 milligram per deciliter with elevated AST, ALT, or ALP levels. Next is, or we have international normalized ratio, that is more than 1.5 with elevated AST, ALT, or ALP levels. So any of these three, one of these three, if it is present, then we can also consider it has to be the laboratory diagnostic criteria for the drug induced liver injury. So these are being provided in the AASLD guidelines. So this is obtained from AASLD guidance. Now continuing with this, so one important factor which helps us to find the type of the drug induced liver injury is the R value. So R value is nothing but ALT, the value of ALT by ALT value, that is upper limit of the normal of ALT, by ALP value by upper limit of normal of the ALP value. So this will give us R value, which helps us to distinguish between the cholestatic type of liver injury, that is drug-induced liver injury, then the hepatocellular drug-induced liver injury, or the mixed pattern. So this R value, if it is less than equal to 2, then in that case it is cholestatic injury. If the R value is greater than 2 but less than 5, then it is mixed type of drug induced liver injury. If R value is more than equal to 5, then it is a type of hepatocellular injury, that is hepatocellular drug induced liver injury. And apart from this R value, the serum albumin levels and the INR, that is international normalized ratio, are usually the markers of the disease severity, markers of the severity of the drug-induced liver injury. And there is a law which is very important, and it helps us to predict the progression of this drug-induced liver injury to acute liver failure. So that law is nothing but the Hayes law, as you can see here. So this is being obtained from the guidelines, that is, in case of an acute hepatocellular injury, the elevation of the aminotransferases can be marked, that is more than equal to 25 times of the upper limit of the normal. The presence of jaundice, that is serum bilirubin more than equal to 2.5 milligram per deciliter with elevated serum aminotransferases, that is more than 3 times the upper limit of normal, and alkaline phosphatase less than 2 times of the upper limit of normal has been associated with a worse prognosis. Worse prognosis, by worse prognosis we mean the progression of the drug-induced liver injury to acute liver failure. And this is the observation which was done by Hyman Zimmerman, and as a result this law is called as the Hayes law. Now coming to the differential diagnosis for drug-induced liver injury, actually if we see, the drug-induced liver injury can be a differential diagnosis for several other conditions, but since the topic is drug-induced liver injury, so in that case we will have to see the differential diagnosis for it. So drug-induced liver injury can be in the form of hepatitis, that is it can be hepatocellular type, it can be cholestatic type, then it can be mainly related to steatosis, that is ballooning of the liver cells, it can be granulomatous type of hepatitis, it can be in the form of pileosis hepatitis. So if it is in the form of hepatocellular type, then the differential diagnosis can be viral infection, alcohol associated liver disease, non-alcoholic fatty liver disease, that is NAFLD, autoimmune hepatitis, Budd-Chiari syndrome, and Wilson's disease. Then if it is cholestatic type of variety, then in that case the differential diagnosis can include biliary obstruction, primary biliary cholangitis, primary sclerosing cholangitis, and also intrahepatic cholestasis of pregnancy. All this can be the differential diagnosis for cholestatic variety of drug-induced liver injury. Next is for steatosis, as it is normal, that is non-alcoholic steatohepatitis, then non-alcoholic fatty liver disease, then alcohol-associated steatosis or steatohepatitis, and acute fatty liver of pregnancy. Then granulomas, for granulomas the differential diagnosis includes several infections which can also lead to the formation of granuloma in the livers. Then next is pileosis hepatis. So in this we have the differential diagnosis as infections, hematologic disorders, and malignancies, where also we can see pileosis hepatis just like that of the drug-induced liver injury. So these are the differential diagnosis for drug-induced liver injury. So it can be some of the reasons which causes hepatitis, some of the reasons which causes cholestasis, some of the reasons causing steatosis, some of the reasons causing granulomatous hepatitis, and some of the reasons causing pileosis hepatis. Now coming to the causality assessment for drug-induced liver injury, the key elements for attributing the liver injury to a drug include: first, the drug exposure should be preceding the onset of the liver injury. The exposure has preceded the onset of liver injury, although the latent period can be variable. Next is other causes of liver disease are excluded. Next is when we do the discontinuation of the drug, it leads to the improvement in the liver injury. Next is rapid and severe recurrence occurs if there is repeated exposure to the drug, that is, however, re-challenge is not advised. So basically this is actually re-challenge, but normally re-challenge is not advised. Another factor that supports the diagnosis of drug-induced liver injury is hepatic injury occurring in the setting of exposure to a drug with known history of causing Dili in other patients. That is, the drug which has already caused Dili in other patients, and if we are giving it to a particular patient And if we see there is derangement of the hepatic function, there is liver function test and liver dysfunction, then in that case we can consider that it can be Dili, it can be drug-induced liver injury. So the different scales which we are using actually includes a variety of scales. So first is CIOMS, that is Council of International Organization of Medical Sciences, Russell Uclaf Causality Assessment Method, that is RUCAM scale. Then we have the Maria and the Victorino system. Then we have the clinical and the diagnostic scale. Out of this, RUCAM scale is the one which is most commonly used. That is, RUCAM scale has been used widely. So let us discuss a little bit about RUCAM scale also. So in RUCAM scale, we are basically awarding points to several components. That is, these are the 7 components. First is the time to onset of the injury following the start of drug. Then subsequent course of injury after stopping the drug. Specific risk factors if present, that is age, alcohol use or pregnancy. Use of other medications with the potential for causing liver injury. Then exclusion of other causes of liver disease. Known potential for hepatotoxicity of the implicated drug. And response to re-challenge with the same drug. So these are the 7 components under which we have several further points, and based on that we are giving points to each of this, and we calculate the total score based on this RUCAM scale. And the drug induced liver injury network group, basically this is a group which has redesigned the RUCAM's criteria and has developed a modified version of it, that is called as RECAM. So RECAM is the revised electronic causality assessment method, revised electronic causality assessment method, which is basically a modification of the RUCAM scale. This is also used nowadays for doing the causality assessment in case of drug-induced liver injury. Now coming to the management, so the primary management without any doubt for drug-induced liver injury is nothing but the withdrawal of the offending drug, that is to remove the offending drug and stop it. So we can do this. Apart from this, there are specific therapies for specific type of drugs, the specific drugs which cause drug-induced liver injury, that is N-acetylcysteine in case of acetaminophen toxicity. Then we have L-carnitine supplementation for cases of valproic acid overdose, that is in case of sodium valproate overdose we can give L-carnitine. In case of acetaminophen toxicity, in that case we can give N-acetylcysteine. Then glucocorticoids can be given in Dili, that is only if it is autoimmune form of Dili, and if there are serious hypersensitivity reaction in Dili, in that case also we can give glucocorticoids. Then in patients with cholestatic liver injury and pruritus, where the patient is having pruritus and the patient tends to scratch and this leads to excoriation, in that case we can also give the bile acid sequestrant, because it is a cholestatic variety of liver injury, so it will sequestrate the bile. And apart from that, we can also give antihistamines to decrease the pruritus and scratching tendency. So these are the basic management, that is withdrawal of the offending drug. First important thing, specific management, that is N-acetylcysteine in case of acetaminophen toxicity and L-carnitine supplementation in case of valproic acid overdose. Glucocorticoids in case of anaphylactic reaction, in case of hypersensitivity reaction. And then antihistamines and bile acid sequestrant in case of cholestatic variety of drug-induced liver injury. Then continuing with this, so the patient should be followed up continuously, serially, with biochemical measurements until the liver test returns to normal, that is the liver function test, that is ALT, AST and ALP should be returning back to the normal. And hepatology consultation should be considered if there is any concern that the patient may be developing acute liver failure. Example, if the patient shows some signs of hepatic encephalopathy or coagulopathy, in that case the patient has to be referred for hepatology consultation, where the end treatment is basically the liver transplantation. That is, in as you can see here, patients with evidence of acute liver failure should be transferred to the transplant center as early as possible for doing the liver transplantation, which is the end management in case of drug-induced liver injury. So this is basically how we manage the drug-induced liver injury. Now coming to the management of the drug-induced liver injury, which is specific to anti-tubercular therapy, and since it is the most common cause for drug-induced liver injury in India, we need to discuss it in more details. So coming to this flow chart, as you can see here, that is approach to hepatotoxicity caused by first-line anti-tubercular drugs in adults. So as you can see here, first is abnormal liver function tests, which is attributed to anti-tubercular drugs. So is one or both of the following observed. We had to ask this question, that is total bilirubin more than equal to 3 milligram per deciliter, then hepatocellular enzyme more than equal to 5 times of the upper limit of the normal. So if both of these are present, then that is it is yes. So what we have to do is we have to discontinue all antitubercular medications and monitor the liver functions weekly until bilirubin is becoming less than 2 milligram per deciliter and hepatocellular enzymes become less than 2 times of the upper limit of the normal. And after this, there is another step, so I will be coming back to it later on. Then, if it was no, that is initially if it was no, then in that case what we will do is we will continue the medication with observation for 3 days. And again we will look for signs and symptoms of hepatotoxicity if it is present or not. If it is present, that is yes, then in that case we will have to do the repeat liver function test. And then again we will look for the parameters, that is if the total bilirubin is more than equal to 3 milligram per deciliter or the hepatocellular enzyme is more than equal to 5 times the upper limit of the normal. And if yes, then again what we will do, we will discontinue all antitubercular medications. And if no, then we have to eliminate the medications based on the pattern of the liver function abnormalities. So I will be coming to this later on. Just in case if there were no signs and symptoms of hepatotoxicity, in that case we can continue the first line antitubercular regimen and we can follow up the patient with liver function test and we can look for the symptoms closely. So next is there is eliminate the medication based on the pattern of liver function abnormalities. So in this, first we will look for hepatocellular enzymes, and suppose hepatocellular enzyme bilirubin and alkaline phosphatase all are elevated and still we are not able to discern the most likely cause of liver injury, then in that case again we will have to do the removal, that is discontinuing all the antitubercular medications. Then if the hepatocellular enzymes are normal, bilirubin and alkaline phosphatase levels are elevated, that is it is basically showing the cholestatic variety. In that case rifampin is most likely the cause of liver injury, so we will discontinue rifampin, that is rifampicin, and we can continue isoniazid, pyrazinamide and ethambutol, and we can monitor the liver function test weekly. So if the liver function test turns out to be elevated even after 2 weeks, then in that case again what we will do is we will have to discontinue all antituberculous medications. Suppose if the liver function test diminished to the less than twice the normal or back to the baseline value itself, in that case we can continue isoniazid, pyrazinamide and ethambutol, and we can add fluoroquinolone, which can be either moxifloxacin or which can be levofloxacin. Following that we will do the liver function test and we can also look for the symptoms. Then if the hepatocellular enzymes are elevated and bilirubin and alkaline phosphatase levels are normal, so it is basically a hepatocellular type of drug-induced liver injury. So in this, isoniazid and or pyrazinamide are the most likely causes of liver injury. So what we'll do is discontinue all the medications as we have said earlier, and then we are going to monitor the liver function test weekly until it is reaching the baseline levels or less than the twice the normal. And after that we are going to do the specific approach, that is of resumption of the tuberculosis treatment, that is stepwise resumption of the tuberculosis treatment. So I will be discussing this now, how to resume the tuberculosis treatment stepwise. So here you can see how do we do the stepwise resumption of the tuberculosis treatment. So following discontinuation of the anti-tubercular medications, what we do is we monitor the liver function test weekly until the bilirubin is coming back to less than 2 milligram per deciliter or hepatocellular enzymes becomes less than 2 times of the upper limit of normal. And then we start resuming the anti-tuberculosis regimen. First we have to begin with rifampin and ethambutol only, because ethambutol is having the least hepatotoxic nature, and following that we have rifampin. Then we can follow the liver function test closely, and if it is if the patient is tolerating well after 3 to 5 days, there is no signs of and symptoms of hepatotoxicity, then in that case we can next start isoniazid. Then again we will have to follow the patient with liver function test closely and look for if the patient is tolerating the regimen properly for 3 to 5 days. Then suppose if it is yes, that is patient is not having any symptoms, then we can continue isoniazid, we can continue rifampin, we can continue ethambutol. And in that case, what we can say is that this drug-induced liver injury was attributed to pyrazinamide, because this is the only drug which is being left. So in that case, what we had to do is we had to complete the treatment with only 3-drug regimen, that is isoniazid plus rifampin plus ethambutol, and we should not introduce pyrazinamide, because now we are definitely sure that pyrazinamide is only the implicated drug here which is causing the drug-induced liver injury. Suppose if the patient is not tolerating well, it means what has happened is that the isoniazid which we have introduced recently, it is responsible for causing the drug induced liver injury. So in that case, what we had to do is we had to just continue with rifampin and ethambutol, and we can resume pyrazinamide, but we had to discontinue isoniazid. And again, we will follow the patients with liver function test, and we will see if the patient is tolerating this regimen properly, that is for the next 3 to 5 days. If the patient is tolerating the regimen, yes, well and good, then we can continue with the rifampin, ethambutol and pyrazinamide, and we can complete the treatment with this 3-drug regimen without the use of isoniazid. And suppose if the patient is not tolerating well, in that case what we can say is patient is having problem with isoniazid already. Apart from that, patient is also having problem with pyrazinamide, so we'll have to discontinue pyrazinamide also. So now what we will do is we will continue the treatment with rifampin and ethambutol, and along with that we can add a fluoroquinolone, that is for the treatment, and we can continue the treatment with this 3-drug regimen only, that is the rifampin plus ethambutol plus a fluoroquinolone. So this is basically the stepwise resumption of the antitubercular treatment in case the patient develops drug-induced liver injury, and how we manage the antitubercular therapy induced liver injury. Now coming to the prognosis. So prognosis is generally dependent on the type of Dili, that is drug-induced liver injury. Most patients with Dili will experience complete recovery once the offending medication is discontinued, or if the dosage of the offending medication is decreased. Next is, some of the individuals can develop adaptation, that is they can adapt to this injury, that is adaptation develops in which injury resolves spontaneously even without discontinuing the medications. That is, even the medication is going on, the patient will be adapted to it. So overall, the prognosis for cholestatic type of drug-induced liver injury is better compared to hepatocellular type of drug-induced liver injury. So this is one important point, that is overall prognosis for purely cholestatic injury tends to be better than that for the hepatocellular injury, that is cholestatic better than hepatocellular. Now coming to the different factors which are associated with the poor prognosis in case of drug-induced liver injury, it includes the following. There is the development of jaundice, defined as bilirubin more than 2 times of the upper limit of the normal in the setting of an alanine aminotransferase levels more than 3 times of the upper limit of the normal. Then, or we have acute liver failure due to anti-epileptics in children, or we have acute liver failure due to acetaminophen requiring hemodialysis, or if the delay has occurred in the presence of any pre-existing liver disease. And we have a score, that is MELD score, that is a model for end-stage liver score. If it is greater than 19, then it has been shown to predict liver-related death in patients with drug-induced liver injury. That is a score, MELD score of more than 19 predicts liver-related death in drug-induced liver injury patients. Finally, coming to the prevention. So preventing Dili, that is drug-induced liver injury, includes educating patients taking the hepatotoxic drugs, example acetaminophen, on their safer use, including appropriate dosing and potential interaction with other drugs or alcohol. As we have already mentioned, that drug-to-drug interactions can be one of the risk factors for causing the drug-induced liver injury. Next is, patients should also be warned about the signs and symptoms associated with hepatic injury and has to report to the clinician once it develops and once the patient notices it. Then approach is basically to monitor the ALT levels in the patients who are taking the medications which are associated with a high incidence of liver injury, such as isoniazid and methotrexate. So in that case, we can diagnose the drug-induced liver injury by the abnormalities in the liver function test. So these are the methods by which we can prevent the drug-induced liver injury. Now coming to the summary finally, so liver injury can develop following the use of many drugs. There are about 1000 drugs and 60 herbal medications also. Then the patients with Dili can be asymptomatic also, And the only way to diagnose in such cases will be deranged laboratory parameters, that is deranged liver function test. Then making the diagnosis of Dili can be difficult as it is a diagnosis of exclusion, and it depends basically on the proper drug use history which we are taking and how we are excluding the other causes of the liver injury. And the primary treatment for drug induced liver injury is nothing but discontinuing, that is withdrawal of the offending drug. So this is the major, that is primary treatment for drug induced liver injury. And these are the references for this presentation, and with this I would like to end this presentation. So I hope you enjoyed the presentation, and if you like my content, please do like, share, subscribe, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.